Welcome to Cancer Explained with Central Care Cancer Center. It's likely that someone you know has been diagnosed with a form of cancer. Learn more about specific cancers, their risks, signs, symptoms, and treatment options by listening to Cancer Explained.
Welcome to Cancer Explained with Central Care Cancer Center. My name is Leanne Powers. I'm the Marketing Director for Central Care Cancer Center, and with me today is Radiation Oncologist Dr. Perez-Tamayo. At Central Care Cancer Center, we are dedicated to keeping expert cancer care close to home. We have state-of-the-art facilities throughout rural Kansas and in Missouri. Whether you need radiation or chemotherapy, maybe access to clinical trials and novel treatments, financial counseling, or other supportive services for yourself or your family, Central Care Cancer Center is here for you. At any time, feel free to email with any questions or comments to askdoctor@cccancer.com. October is National Breast Cancer Awareness Month, so today our discussion on Cancer Explained centers around breast cancer. Good morning, Dr. Perez-Tamayo.
Good morning, Leanne. Thank you for having me today.
First off, I just wanted to say or just ask the question, obviously breast cancer begins in the breast, but how does it form? How does it start up?
Well, that's an excellent question. I actually go through this with all my patients, but this should be something that is shown even in high school because it is a process that all people with breasts, of course, all mammals have breast cancer, so they can get breast cancer. We're talking about men and women. In women, however, it is the number one cancer of all the bodies. In fact, over 250,000 women are diagnosed with cancer of the breast in the 2019 estimates. And that's a huge amount of cases. Much of them are early and can, in fact, be cured with simple treatments that we'll go over later. But how this process occurs is something that is not completely figured out. There are a lot of known factors and a lot of unknown factors. Number one, there's several kinds of breast cancers, but the number one cancer is of the ductal carcinoma. And what that is that if you can imagine your breast being like a shrub, let's say, and the branches are the ducts that lead to the nipple, which was the trunk of the shrub. The breast is a organ that particularly is made to breastfeed or to produce milk, which is not produced by these duct cells. In fact, the duct cells usually produce a little slippery substance called mucin, which can make the droplets of the milk that are produced in the buds or the very end of the branches by the lobules. And these lobules are blind sacs that have a different type of cell. They look like teardrops versus the cuboidal or like cubes in the duct. So what happens is that something occurs within the ducts, which usually are produced from either a genetic tendency or just because actually most of the breast cancers are not genetically linked, but something happens to the ducts that make them start replicating or growing too fast. So we, as women that are older, and this is a cancer mostly of older women, but certainly you can have women in their 20s have breast cancer, start getting the ducts with something called hyperplasia or overproduction plasia, like a hyper child. And since whatever is causing this to happen is speeding cells that have usually very, very slow turnover rate to divide haphazardly, they become odd or atypical. These atypical cells then basically can plug up the duct and start, in fact, infringing upon the duct and coming out of the duct into an infiltrating type of cancer when they become malignant enough. So this, and what causes this? You may go, I always draw a picture of a duct that is replicating in a fast fashion and an arrow that I always put a question mark on because there can be many factors that are causing this replication. You can have a tendency, let's say, in your body because of your genetic makeup that you have fragility of your chromosomes, meaning that, like if you're allergic to cats, maybe one cat will just make you go into an anaphylactic reaction, but maybe it takes a whole herd of cats to make somebody else get into a problem. But maybe you're one of those sensitive types that something caused you to, just go overboard and you start dividing the cells in an abnormal fashion. These things can be many. It could be toxins of certain kinds. In fact, even smoking is linked to breast cancer, but it also can be stress. And stress actually is almost the number one reason why people kind of push themselves into a problem. There was a study many years ago where they took women from Asian countries where there was a very low incidence of breast cancer, genetically speaking, and they followed them as they moved to California. Then they saw that instead of having 1 in, let's say, 20 chance of having cancer of the breast as seen in their country, they go up to the American standards, which is 1 out of 7. So what happened? Well, it's the lifestyle. We are go, go, go. You are not stopping and distressing. Things bother you. There's a famous book, I think it's called Don't Sweat the Small Stuff or something like this. And it's true. Things that, you may not be aware of it, but they may be causing you to have a reaction. And just like you can cause yourself an ulcer in your stomach from stress, you can cause yourself other diseases, including heart disease, from stress. So here it is. You have this arrow that produces this stressful situation or fragility of the chromosomes. But this arrow is not focused on one spot of your breast. It is affecting all your breast tissue, which may be both sides. So once you have one breast cancer, you are higher risk of having another one in the same breast or in the other breast.
So do all breast cancers then start like as a lump in the breast?
Well, not really. They usually start in the duct, and the duct then becomes inflated or plugged up like you would step on a hose. And then it starts spilling outside the duct. And each duct is actually very fragile. So it's surrounded by this adipose tissue or fat, which support the duct. So when you are lactating or breastfeeding, these ducts are actually bigger and they are full of milk. So you need something that can easily be compressed and also supportive. So what happens is that what you're feeling as a lump is just the hose becoming big, and then the infiltrating process. Now, in a mammogram or other type of imaging, it looks stellate or like a star because it has points. Cancer is like bindweed. For all the Kansanites who are fighting bindweed in their garden, the roots can be longer than you expect. Cancer of the breast from inception can be systemic, meaning it's already trying to get into your blood system. And that's not too surprising because, of course, you have a lot of blood supply in the breast. You have lymphatic channels. And these tumors, these plugs of tumors can then invade these structures, which are hollow, like your blood, if you can imagine your veins in your arm, how they're flowing with blood. Well, likewise, you can have these lymph channels, which are full of lymph, which is a fatty substance, that clears abnormalities from that area and sends it to a lymph node, which is a way of like if you can imagine a train station and the train tracks being the lymph duct, taking it to a lymph node, which then the purpose of a lymph node is to identify what it is. So if it's a infection, let's say you're breastfeeding and you get mastitis from a little cut from, let's say, the nipple that gets chafed, and people that have breastfed have, this experience. Well, this lymph node then sends a message to your immune system saying, look, I have a strep infection up over here. I need the special cavalry that comes in and cleans up strep specifically.
Yeah.
So when it comes to cancer, since it's your own cells that went berserk, it doesn't know what to do with it because it's your own body, and obviously you're being also stressed and entertained by, it could be by depression, for instance, depression or chronic stress from taking care of an ill child or an ill parent, or that your house burnt down. You're so, entertained elsewhere that you may not be able to identify this as something that needs to be cleared.
So when you talk about breast cancer, how common is it? I mean, as far as for women, I mean, it's besides like skin cancer. Is skin cancer like the number one, and then like breast cancer?
Well, yes.
I think.
We don't count skin cancer really when we're looking at statistics, because really skin cancer is actually the most common cancer of all in all. But we're talking about more of organ cancers. Breast cancer is the number one cancer. 30% of the cancers in women make up breast cancer. And even though it is not the number one killer, because actually, unfortunately, women started to smoke as men did, now we're almost par to par with men. In fact, it's 24% of men die of cancer of the lung, and 23% of women from cancer die of lung cancer, which it used to not be the case. But breast cancer is second. There is about a 15% death rate from cancer of the breast in women a year.
Are we seeing, do you think, in your opinion, professional opinion, any kind of a downward trend in breast cancer between research and technology or anything? Or is
prevention?
It just,
no. We are detecting it earlier.
Yeah.
The treatments are better. We're also finding that what we thought was a generic breast cancer of the duct is not as generic as we think. The behavior is different. There's now even more immunochemical and genetic testing being done on the cancer that tells you that it is not as malignant or more malignant than it looks. So even with cancers that are very small, microscopic, even millimeters in size, they don't react always the same. And therefore, the treatment is not a one-size-fits-all. We have now more tools to ensure that maybe you need a little more insurance than in the past we would have given you.
Again, I'm with radiation oncologist and president of Central Care Cancer Center, Dr. Perez-Tamayo. Now, we've been talking about breast cancer, as October is National Breast Cancer Awareness Month. You're welcome to, of course, email anytime with your specific questions to askdoctor@cccancer.com. And doctor, I just wanted to talk more about hormones and the role that they would play when it comes to breast cancer.
Well, breast tissue and other tissues in the woman's body have receptors. Receptors, if you can imagine those old-fashioned toys for kids that have like a little triangle and a circle and a square, and you would put a toy that fit the shape. These are receptors. Receptors come in different shapes, and they tell the cells what to do. So estrogen and progesterone and other hormones or directives are what turns on or turns off the cell to do certain things. Because we're women, we have receptors in all of our cells that tell us to become a woman. We grow breasts, the ovaries start ovulating, we have cycles or periods, we have female looking faces and hands and feet and ears. You cannot hide that. It's something that is produced from the beginning, from the very moment you become a female. The receptors that tell you you're a woman are in the breast tissue, and these receptors can be in the tumor, in the cancer, very, very prominent. You can have 100% receptor positivity, meaning that your cancer is all hinged on estrogen as a driver, or progesterone, and others. HER2, for instance, is another growth promoting protein that is in breast cancer tumor cells. And if you can imagine the Pac-Man, those used to be a very old-fashioned game where it has a mouth and it would eat something. Well, these tumors eat estrogen and they start growing and become real healthy.
Okay.
And if you can turn that off by using some sort of either turn off the hormones by removing your ovaries or removing a blocker of hormones, or actually you can make them sick. You can make them thin and then the body can then take over by saying this is not a healthy cell and eat it up. So these ways these keys or these ways of turning off and on a cell can be vital to the treatment, because if we can manipulate that, imagine that makes a huge difference. And that's why in people that have a family history of cancer of the breast, sometimes there were trials where we used hormone blockers to prevent these cancers to grow or to start up, because they would be manipulating the estrogen receptor. But it's not as easy, as we develop in science, we get to see that no, it's not as simple as we thought, but it's one of the components.
At least you try, though, too. I mean,
there's definitely information, and it does work, and we actually are treating patients after the completion of our treatments, whether chemotherapy is part of it and radiation and surgery. We do give people even 10 years of estrogen blockers if they have an estrogen receptor positive cancer, because we know that not just, again, remember the arrow I told you, the arrow does not affect just one part of your breast, it affects both breasts. So this estrogen blocker is more of a prevention for the other side than the treated side.
So you've always said, I mean, as long as we've been, doing and talking about specific cancers, to be your own advocate. You know how your body feels. If something feels wrong or out of place, you need to talk with your local provider, at least get it checked out. And I think that definitely goes with, getting a regular mammogram or even doing your self exams and treatment, screening tests and stuff. So finding breast cancer early, of course, just like with any other cancer with the screening option, I mean, you have a better chance for a successful treatment, true?
Very true. In fact, I always insist that people don't give up on just going to one place if they're not getting satisfaction. Yeah. If you feel that there's something wrong, and it could be as simple as, I'm just out of proportion tired. Tiredness is a very big sign for something wrong. Or chills, for instance. People just think, oh, I'm not going to think about it. I'm just a chilly type of person, or I'm just tired because I'm answering more of phone calls, or whatever you feel like, but it's out of proportion, or you're losing weight for no reason, and you go, yay, I've always wanted to lose weight. It may be a bad sign. Yeah. So go and look up, someone that can help you. And if you don't feel that that's getting you somewhere, go to somebody else.
As far as the risk factors, I mean, you mentioned too, like lifestyle. It could be lifestyle related, but as you get older, I mean, most breast cancers are found in women age 55 and older, but that doesn't necessarily mean that you can't get it within your 20s. But what about an increased risk for those women that may not have children? Is that somewhat of a risk factor? Or?
Well, it's been debated back and forth. The children, if you breastfed, if you used oral contraceptives, if all of these things are still in fact, even smoking is a debatable risk factor. And I don't know that we have the answer right this minute. We know for a fact that if you are taking estrogens as a supplement and you have breast cancer, you're feeding the cancer. So there's no doubt about that one. In addition, that if you have a stressful life, you're going to have sicknesses of all sorts. So that we know. And is it worth it? The answer is no.
As far as the signs, symptoms, I mean, of course, lumps. It's like, a hard marble-like?
The examination of the breast is not like, I'm going to mass your breast and then that's that. It actually sometimes is the position of where your body is in comparison to your breast that can pick it up. I have had so many women say, I was talking on the phone and I was just feeling under my arm, and there all of a sudden I felt this hard, bean-like hardness that wasn't there. And it feels just like a bean. But you examine your breast as if it was a clock. You take your time. And you may be lying down, you may be sitting up, maybe you're in the shower. Doing it in different positions is always a good thing. And what you're trying to figure out is this firm. Most women will have some fibrocystic changes. Fibrocysts are just changes in the breast that are benign and they feel lumpy, but they don't feel hard. Fibrocystic lumps are normal, but they don't feel like cancer. Cancer feels very distinctly hard, and especially if you have dimpling. What does that mean? It means that you're lifting your arms up in a mirror and you're seeing that there's a dimple, like you would have a dimple when you smile in your face. That's what it looks like. It's a little dimple. And maybe when you put your arms on your hips and you press, you make those pectoral muscles pop your breasts up, you can see the dimple, or you have a dimple discharge. There's a little bit watery or even bloody discharge. That would be a sign. Or pain. Pain is usually not a symptom, but it can be. The breast tissue goes all the way into the axilla or your armpit, And there's lymph nodes there as well. So if you examine your breast, that you need to go all the way into your armpit, and then you can, feel something. And
what about those women that might have had breast implants or a breast reduction? I mean, they still need to be checking themselves, correct?
Absolutely. And in fact, this is one of the big issues with treatment, with removal of breast, even if you have like breast cancer in the family and you prophylactically remove your breast, you can't remove all your breast, okay? Even if you have a mastectomy, even a radical mastectomy. In the older days where they used to remove even your chest wall, you can't remove all the breast tissue because your tissue is hinged upon your skin and pectoral muscle and other parts of that area. So yes, you lower your risk tremendously, but you still have the chance of having breast cancer. So if you have an implant, for instance, either underneath your implant or above the implant under skin, you still need to have it checked out because you can get breast cancer, especially if you have a family history. Now, let's say you have had cancer, a personal history of cancer of the breast, even more concerning that you could have a recurrence underneath the implant or on top of the implant.
Okay, very good. And now let's get into the prevention and kind of treatment options, as well as let's talk about breast cancer in men.
10% of cancers of the breast are in men. And you would think that because the breast tissue is actually smaller, that we are going to pick it up earlier. And that's not the case. Maybe because we're not expecting it. I don't know why. But sometimes breast cancer in men is genetically predisposed by certain markers. The BRCA 1 and 2 can be genetically linked. And these are very, very aggressive cancers. In fact, maybe my supposition is the breast cancers in men that I have seen have always been far more advanced than in women. And that is because I think that quickly, early on, they start invading the skin or they start invading the muscle because of the breast tissue is very small. Now, this is why also in women, it's not the same thing to have a 1-inch cancer in a triple D breast than a 1-inch cancer in a double A breast. Very different. The proportion of breast tissue around the mass and the amount of margin you have is huge. Now, many people don't have that as a concept, but it is an important part of the equation as how to handle it, especially when you're wanting treatment that we call breast conservation. So it has more to do with the aesthetic result. Yes, we want to cure you, but also we want to give you a good aesthetic result. So a lumpectomy is certainly an option for women that have the tissue or the location that lends itself to a good cosmetic result. You can have actually a lot of breast, but if this location is very medial, in other words, towards your sternum, you may not have a very good result by just a lumpectomy. You may have to have a little bit of plastic surgery along with your lumpectomy because we want to give you a good breast. Now, why is that important? Because the breast tissue is a sex organ and also a psychological organ. I think that women, because they've had breast all their lives, or especially if you're young, you're getting married, you have, this is an important part of your makeup, your psychological makeup. So a breast that is, even a breast that is not perfectly beautiful, it is, beautiful to you.
Yeah.
And also you have the feeling when you have a mastectomy or a reconstructive surgery, you lose completely 100% sensation. Doing something radical like a radical mastectomy does not mean, okay, I'm done with all my treatment and that's that. Again, I'm going to go back to Dr. Fisher that said from the inception, these cancers are systemic. Doing a radical mastectomy doesn't mean you're not going to need radiation or you're not going to need chemotherapy, or you may need chemotherapy before even the mastectomy. It's called neoadjuvant chemotherapy, which is given now in many women that have certain features. So you have to have everything done from the very beginning in the right order to be successful. There is no doubt in the literature that shows that for women that are treated in the right, correct order, whether you need the chemotherapy before your surgery, and then after your surgery, or you can have your surgery first. The right order is key to the success in your outcome for survival. We're talking about survival. Now, radiation treats different things than the chemotherapy. Chemotherapy is a word for chemicals. And these chemicals can be many types. It can be chemotherapy as you would hear it, where you have an IV or even an oral medication, but it can also be a hormone treatment that blocks hormones, and it can be also like the HER2 receptor, which is, again, as I told you, a mouth that can be blocked by a medication that does that, Herceptin. Or it can be now the new immunologic agents that actually are going to treat you immunologically in a different way. Now, neoadjuvant, neo means new, so adjuvant means in addition, so you're going to get something before you get your surgery. And then the radiation actually is something that is going to address what I call the nooks and crannies that cannot be addressed by either surgery or the chemotherapy. And those nooks and crannies are places where we know for a fact people fail because maybe the chemotherapy doesn't reach to the levels that are therapeutic, like the skin. The skin can harbor cancers of the breast because if you can pick up your skin from your hand, you can see that it's not attached to the other parts of your hand. So the cancer can lie between planes, the planes of the muscle, the planes of the skin, maybe the implant, or it can lie between fat planes because this cancer has now been infiltrating fat, which cannot be removed fully from the area. Or it has involved the lymph nodes, and the lymph nodes, removal of the lymph nodes, that's why they don't remove lymph nodes as they used to, because it doesn't really remove the channels that take the cancer to the lymph nodes. So imagine removing the train stations, but not the train tracks that are carrying the trains full of the cancer. So I treat the tracks. So what I compare myself to is like Roundup, where I'm treating the roots and the roots of the bindweed that has been removed. I have to treat now the nooks and crannies that are not addressed by surgery. Surgery has to cover you with the skin. You can't be an open area. And so then we treat the areas that are that are of concern. Now, in other modalities of radiation can treat just the lumpectomy site alone. We have now new techniques where you can have radiation just to the site. If you're only at risk in the lumpectomy area, you may be a candidate for accelerated radiation that is local. And that's only a few treatments. Or you can do something called hypofractionation, meaning 16 treatments instead of the classic 30 treatments for some patients. You also may qualify for the radiation that is an implant to the site. You may need actually radiation to all the lymph nodes. And the lymph nodes are not just the ones in the axilla or under the arm, but they may be the lymph nodes underneath the pectoral muscle called the rotor system, or the lymph nodes in the middle where they're underneath the breastbone called the internal mammary. Your cancer may be in the internal quadrants and may drain to those lymph nodes. And then you may need to be having the lymph nodes covered in the above the clavicle or supraclavicular, or below the clavicle, the infraclavicular. So you can imagine that these lymph nodes are like, as I told you, they're all connected through lymph ducts. And these lymph ducts or train stations go everywhere. So you have to treat all the systems to make sure that any of the trains that went to, the west, the east, the south, the north, that are covered. And that's what I do. We are more about the skin, the nooks and crannies, the interfaces, and the lymph nodes and lymph node channels.
When it comes to radiation, treatments. As far as the different types of breast cancer, I know that you mentioned like HER2 as being, a possibility with the cancer, but I actually spoke to a breast cancer patient and survivor who had the triple negative breast cancer, is that a common diagnosis?
Unfortunately not. Triple negative cancers, even if they're small, are more malignant. What does it mean? It means that we cannot manipulate them with the estrogen or the progesterone or the HER2. And basically, if you can imagine that toy I told you about where it has a triangle, a square, a star, this comes in a solid ball. There is no receptors. So nothing can actually manipulate the cancer to be shut off. So it continues growing because it doesn't have a switch to turn it off. So then we have to do toxic chemicals or chemotherapy that is going to go directly into this ball by affecting it in a different way because it doesn't have receptors.
Okay. Thank you so much, Dr. Perez-Tamayo. It's such an important topic, especially here for October being Breast Cancer Awareness Month. Well, we appreciate you taking the time to listen to Cancer Explained with Central Care Cancer Center. With facilities throughout rural Kansas and in Missouri, Central Care Cancer Center offers complete cancer care all under one roof, so there's no need to travel far for the best in care. Whether you need radiation or chemotherapy, access to clinical trials and novel treatments, financial counseling, or other supportive services for yourself or your family, Central Care Cancer Center is here for you. You have a choice. Bringing expert care to you is an important component in the success of your outcome. In fact, being surrounded by your family and friends, that can be the factor that elevates your treatment. Feel free to reach out by calling 800-592-5110, or you can always visit us online, cccancer.com. And you can always send an email to askdoctor@cccancer.com. For Dr. Perez-Tamayo and all of our amazing providers and nurses, I'm Leanne Powers. Thank you for listening to Cancer Explained with Central Care Cancer Center.
You've been listening to Cancer Explained with Central Care Cancer Center, offering expert cancer care that's close to home. Central Care Cancer Center has clinics throughout Kansas and in Missouri. Central Care Cancer Center, online, cccancer.com.